welcome to Bandage Banter. Guys, this is this is episode 7. I'm Sam. I've been in healthcare long enough to love it deeply and to question it honestly. This is a space where we talk openly about healthcare, the moments that we rush past, normalize, or we just truly don't even say out loud. I'm really glad you're here, so let's get on into it. Today, we're going to be talking about a word that seems or sounds harmless, and that word's efficiency. And if you work in healthcare, you've already heard it 1,000 times. Efficient nurse, efficient workflow, efficient discharge, efficient throughput, efficient unit. It's always said like it's a compliment. But in healthcare, efficiency is not a neutral word. And that's what we're going to be talking about today because that's the section of the book we're on. Efficiency is a value system. And once efficiency becomes the value, it changes the system rewards and what the system punishes. Efficiency is usually sold as being cost cutting, like the hospital is just trying to save money. And yes, it does eventually, but efficiency does not enter healthcare as savings first. Efficiency enters healthcare as predictability. So, because predictable movement is what allows control, and control is what allows profit. Speed creates predictability before it creates savings. Here's the simplest way to say it. Efficiency standardizes movement. It reduces variation in how long tasks take, how long a patient stays, how long an admit takes, how long a discharge takes, how long it takes to turn a bed over, and how long it takes for the chart to close. And that matters because variance is expensive. Not because variance is normal, but because variance disrupts planning. But because variance disrupts planning, which is all that efficiency is based around. A system operating on narrow margins cannot tolerate unpredictability. So it targets the one thing that creates it. Humans. Judgment. Efficiency does not measure care. Efficiency measures movement. It measures when something starts and when something ends. For example, medication scan, an order acknowledged, patient discharged, chart closed, call light answered, ding, bed assigned, transport requested, patient moved. Efficiency is obsessed with, guess what? Timestamps. But here is the issue. The most important parts of care do not have clean timestamps. Let's name the work that never shows up in report. The moment you pause because something feels off. The moment you look at your patient and you're like, my spidey senses are going off. The moment you re-enter a room when you've already been in there twice, or the moment you reach out to a provider even though their labs or things aren't critical yet, or what about the moment you slow down to double check a med? The work does not begin and end cleanly. It has cognition, vigilance, judgment, and the system doesn't know where to put that. It doesn't know what to do with that because it can't measure it reliably. This is where we need translation. When the system says we need to improve efficiency, what it means is we need to reduce variation in how long human work takes. Not because patients don't deserve time, but because time that can't be predicted can't be monetized cleanly. We're going to talk about 3 examples, and I'm sure most of these will come to you and you'll be like, oh yeah, that's true. Let's talk about the first one. Discharging before noon. I can spend a very long time talking about that whole entire process. Every nurse has heard it. Sounds harmless. It sounds like organization. Most patients love it. But here's what discharge before noon actually means in practice. It means the hospital wants the bed open earlier so they can admit another patient earlier. So the bed doesn't sit empty. So the revenue keeps cycling, keeps moving. And no, I'm not saying that this is evil, but I am saying it's not about care. because the patient doesn't suddenly become ready for discharge at 11:59. They become ready when the meds are reconciled, case management has done their role, PT, OT, speech has done their roles, the teaching is done, family understands, and they have a support system, hopefully. Follow-ups are arranged, equipment is ordered and already at the home, patient stable, ride is confirmed. That is the reality. But efficiency doesn't care about reality. Efficiency cares about, guess what? Timestamp. We're looking at the moment that order was put in to the moment that that patient rolled off the unit. And guess who becomes the one that compresses reality? Nurses! Ting, ting, ting! You're the winner! Come on down! So, let's say that you do it right. You sit down with the patient, you explain their new diagnosis. Let's say it's diabetes. So you're doing the instruction, whether it's them taking a new medication or it's insulin. You answer the questions. You make sure they feel fully supported and understood. And you do the thing that prevents a bounce back. And guess what? What does the system see? It sees delayed discharge, delayed discharge. It's like it's on a microphone. It doesn't see that you just prevented a readmission because you took that time to further education. Because the prevention never becomes a number. When the system says we need to improve discharge efficiency, do you want to take a guess what it means? Ding, 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 ding. The Jeopardy theme song. It means we need beds to open on a schedule. And if that schedule requires compressing human care, guess who's gonna be the one to do it? Nurses! Efficiency measures time. It does not measure meaning. Efficiency is blind to meaning. To a metric, 10 minutes of patient teaching is indistinguishable from 10 minutes of delay. A pause to reconcile a medication list is indistinguishable from slowness. A second look is indistinguishable from incompetence because time is time. And that is how efficiency becomes dangerous. Not because speed is evil, but because speed becomes the only thing that is legible. Let's talk about the second example I'm going to give you, which is medication scanning. Medication scanning's good. Barcode scanning reduces error. I'm not anti-scanning, let me get that straight. Although my rates are probably horrible. But here's what the system does. It turns medication administration into performance metric, not a safety process. So now you're being tracked on time to med, late meds, missed meds, scanning compliance. And if you've ever been a nurse, you know this. You know that a medication is not late because you're lazy. Medication is late because you're short-staffed, the patient is off the unit, the patient is off the unit, the medication isn't in the Pyxis or available on the unit, pharmacy didn't verify, IV infiltrated, patient's vomiting, patient's asleep, patient refused, you got pulled into another room, you were in the middle of something more urgent. But the metric does not see any of that. The metric sees late. So guess what we nurses learn to do? Scan fast, close the task, clear the chart. And now we have a safety tool being turned into a speed tool. Efficiency rewards closure. Completion, it rewards the visible surface of the shift. What medications were administered, what charting was done, what orders you signed off on, the discharge that was put in place, and the bed turning over. And in a sense, it punishes anything that requires deliberation, conversation, reassessment, and my least favorite of all, ethical pause. Another example, if it hasn't quite related to you yet, and I know everyone knows this one. If it wasn't documented, it wasn't done. And I understand why documentation exists. If anybody knows me, I will tell you flat out my thoughts on documentation, but documentation has evolved into something else. It has evolved into proof of billing, compliance, and liability, and that changes what gets documented. Because now charting isn't about telling the story of care, it's about producing defensible data. So the nurse learns, chart what closes the loop. Patient education provided, check. Patient verbalized understanding, noted. No new orders, charted. Continue to monitor, which we don't really use anymore, by the way. The words create a trail, but the work that produced these words often does not exist in measurable form. This is the part that most people miss. Efficiency does not erase work, it relocates work. Work that can't be measured doesn't disappear, it's absorbed into the clinician. And I know if you've seen my previous episodes, you know I will hammer this into you. It becomes more mental load, more vigilance, more interruption recovery, more moral pressure, and more cognitive labor. And because it's invisible, it becomes hard to defend. Let's kind of connect this all into money, because a lot of people think efficiency and money are really tight. Because this is where people think the conversation is going to go first. They think hospitals want efficiency because they want savings. But again, speed creates predictability before it creates savings. Once movement is predictable, staffing can be lean. Because lean staffing depends on one thing, the assumption that things will happen on time. Buffers can be removed, slack can be labeled as waste, and when slack is treated as waste, risk has nowhere to go. So it gets pushed downward onto bedside. And it extends a little bit farther than that. It's pharmacy, RT, of course your CNAs and your nurses, the clinicians, the providers, but efficiency is often described as a preference. Like, we're just trying to streamline, we're just trying to improve the flow, we're trying to eliminate waste. But once you remove those buffers, efficiency stops being a preference. It becomes a mandate, because now the system cannot tolerate anything going slow. Not because the patient can't tolerate it, but the margin can't tolerate it. Again, 5 minutes is 5 minutes. There's no adding to those moments. And that part feels personal, but it isn't, because the system doesn't say, we designed this with no buffer. The system says, why didn't you keep up? So you leave the shift exhausted, and not necessarily because you were help lifting and moving patients all day, but because you were honestly thinking constantly, tracking, anticipating, recalculating, and holding risk in your head. And the system reads that exhaustion as burnout. You're burnout, you're burnout, you're burnout. It's not strain. It's not our design. Girl, no. This is one of the core ideas behind my book, Nurses Aren't Burnout, Nurses Are Exploited. Because exploitation isn't always someone yelling at you. Sometimes exploitation is a system that quietly relies on your cognition, your memory, your vigilance, your judgment, your moral drive. A system that uses your brain as a buffer, and then turns around and evaluates you by numbers that can't even see the work that you did. Efficiency is not a neutral word. Speed lowers variance before it lowers spend. Predictable movement allows margins to be tightened, buffers are removed, and risk is pushed downward without appearing unsafe. Control is the objective. And next week, we're going to be talking about the next section in my book, which is what happens when efficiency stops being a goal and becomes the environment. Because once speed becomes the air that you breathe, you stop noticing how little margin that you have. And when something finally breaks, the system doesn't ask what the environment demanded. It asks, who failed inside it? Thank you so much for spending your time with me. I hope this helped you notice something that you've been carrying and realize that it wasn't just you. Thank you so much for tuning in to Bandage Banter. Again, I really enjoyed our time together, and I hope it felt like time well spent. Be gentle with yourself, and I hope you have a lovely week. Toodles! Mwah!